encouraged us to start our clinic 25 years ago. So he called me. He said, well, he said, believe it or not, I thought I didn't have Cohen syndrome patients in my clinic. But for the last 3-5 years, I saw, more than handful of Cohen syndrome patients. And then, and also, I have two very prominent, the scientists and then research. They're interesting. They're interesting in Cohen syndrome. He said, would you care? One day we have this Cohen syndrome gathering as a doctor, scientist, just a few of us. And then, he proposed to have meeting in his clinic. So by doing that, we all can see his patient, with Cohen, and then we come up with some idea. So I was so excited. I said, well, for years I reach out to many lab research scientists, physicians, trying to engage people working on the Cohen syndrome. But we, it's hard to get people interested. But all of a sudden, we have almost have a handful of people. They become very interested in the research on the Cohen, and then also they have patients. They take a sincere interest. So I was all excited. Well, let's do that tomorrow. But of course it wasn't tomorrow. But we had some planning to do. But 1 year ago, we had a gathering in central Pennsylvania, and then Dr. Miao He is one of the person who was invited during that conference. You will see when she does the talk, her screen show Dr. Wang, because I forward her my link to her, so that's why her screen ID is Dr. Wang. But her name is Miao He. Its last name is He, but it doesn't pronounce as he. It's actually pronounced as her. Not because she's female, but that's just a Chinese pronunciation. It's not he, but it's her. But long story short, she was trained in United Kingdom. She has a postdoc training in Mayo Clinic. She has her clinical biochemical genetic training in UPMC. She is currently as a co-director of lab for the Children's Hospital of Philadelphia, and also associate professor in UPenn. She has co-author over 80 publications. It was interesting. I want to, before I finish my talk, I turn to her. I want to say a little bit that day. We actually spent 2 days. See 5 patients with Cohen syndrome, and then we supposed to discuss 2 diseases, but that day, that 2 days, we spent 80% of the time just talk about Cohen syndrome, and then we talk about what we could do together, and we actually started the Cohen syndrome research consortium that day, and then make the plan, start point, how we could get a funding, and also, almost 2 months after we have some result, and then, its studies ongoing, and then, I reach out to Dr. He this week, and I said, well, would you, it would be great if we could use to present some preliminary data. And then she said, well, this is still raw data, but then last 3 days, she really spent a lot of time put the raw data together as a slide and to share with everyone. I'm very grateful, and also very nice to have her to join me and to be part of this conference. So thank you, Dr. He, and then I'm going to stop sharing my slide, and so I can turn to
And Dr. Wong, are you going to then speak? Would your preference be, because we're going to have questions that come in. So after you both, after Dr. He is done, then way you guys can both answer questions.
Oh, definitely, yes. Yeah,
okay, that's what I figured.
Yes, yeah, and then I'll stay for most of the day today, and you.
Perfect.
Yeah.
Sounds great. Okay.
Thank you, Dr. Huang, for the introduction, and we'll see what I can get my slides up. Am I sharing the slides?
Yes.
Okay, great. You can all hear me. This. So I'm going to talk about, let me see what I can minimize this. I'm going to talk about characterization of glycosylation anomalies in Cohen syndrome. As Dr. Huang mentioned, I'm a clinical biochemical geneticist. I'm not a medical doctor, and I run diagnostic lab instead. So we don't see patients, we see tens of thousands of blood sample, urine samples every year, and make diagnosis on those specimens. That's my day job. And in addition to that, I'm also a site PI for CDG consortium at the Children's Hospital of Philadelphia. So what is called close to my heart is glycosylation disorders. So you may ask why a geneticist care about glycosylation. So by now we all know, as a human, we have about 25,000 genes. And those genes sit in the nucleus, and they can be transcribed to about 100,000 transcripts, that's mRNA. And then that produce protein. But 100,000 mRNA is still not enough to explain our complex life. But if we look at distinct covalent forms of proteins, we really look at more than 1 million different proteins. Why is that? Because protein has more than 200 post-translational modifications. So those post-translational modifications, the most important ones occur in Golgi. So among all those modifications, N-linked glycosylation and O-linked glycosylation are most complex. So if we want to say what really determines our life, then I would say those glycoproteins play the major roles. That's why as a geneticist, I'm very interested in this area. Glycans are everywhere. I can tell you that not a single living cell on this earth is not covered with glycan. And even for some pathogens, they are covered with glycoprotein as well. So such as the COVID virus. And the one that get a lot of spotlight is the spike protein. That's a glycoprotein. So if you just come out of medical school, a lot of you will ask me, how about glycation? Is glycosylation is equivalent to glycation because you learn about glycation from diabetes? The answer is not exactly. Glycation is not exactly glycosylation. It's a chemical reaction between glucose and the protein. Glycosylation is a complex sugar chain that is synthesized de novo. But glycan is not, but all of us know about the glycan. If you know about your blood type, you know about glycan because the ABO blood type are determined by glycan. Similar to DNA, there are common things for glycan. So for DNA, we know there are 4 different keys to determine DNA. That's A, T, G, C. For glycans, we have 8 different keys. Those are the common keys. But different from DNA, glycans is 3D. So the linkage between each keys are different. That make the glycan really diverse. This is showing you the pathways that used to make the final glycan products. So the pathway probably is the longest pathway that I've memorized in my career. So as a biochemical geneticist, we are all about pathways. One of the most common CDG is known as PMM2 CDG. So that is here. So that is an enzyme in the cytosol and involved in making the building block for glycosylation. And where the colon enzyme is at the cis part of the Golgi. So they are at a different position. In the pathway-wise, the PMM2 is at the very beginning of the glycosylation pathway and affect multiple initial steps of glycosylation. So from what we see in plasma and glycan from Cohen syndrome patient, so our prediction is a glycosylation defect in Cohen syndrome is at the distal part of the pathway. So you can see that from position of where these 2 defects are, we can predict that Cohen syndrome will be a lot milder than PMM2. So another thing to talk about is now we know Cohen protein is in Golgi. Golgi is a very unique subcellular organelle. One reason I said so is because it's highly dynamic. So that means the size of Golgi will change depending on the demand. So if there's a high demand for making glycoprotein, such as like doing acute infection, body need a lot of cytokines, a lot of antibodies, then the Golgi will grow very big and produce a lot of protein. But when there is no stress, say no infection, then the Golgi has to have ability to shrink to a very dense, small organelle. So if Golgi cannot perform this capacity, then the glycosylation will be defective. A lot of proteins and the lipids that live on Golgi play a role in Golgi dynamics. Another thing that is very important for Golgi is the trafficking. So Golgi is like a center for intracellular trafficking. It controls the glycoprotein being trafficking to ER, also proteins from ER also trafficking to Golgi, and also controls glycoprotein trafficking to lysosome, endosome, or cell membrane. So if the trafficking between Golgi and other subcellular organelle doesn't work, then that also causes glycosylation defect. So what is congenital disorders of glycosylation? That refers to genetic defects in human glycome. Over 900 genes encode proteins for glycosylation, and more than 10% of the proteins have unlinked glycosylation in human. So far, we have discovered 13 distinct glycoconjugate biosynthesis pathways. Over 170 disease-causing genes have been published for CDG. Many still remain unknown. So some of these are the new diseases that are yet to be discovered. Some of these are existing disease, known disease that actually is not recognized for their glycosylation defect. So in 2019, Frontier of CDG Consortium was formed that was funded by NIH U54 grant. So when we wrote the grant, we proposed to recruit 70 CDG patients to our consortium. And NIH very much sent it back to us and saying, well, other consortiums are recruiting over 2,000 patients. You only do 70, that's not enough. So we discussed, all the PIs discussed with each other, and we went back to NIH and saying, okay, we're going to recruit 90. We're going to recruit more CDG patients, but 90 is our final offer. And NIH took it. So we got funding to recruit 90 patients. And now we are the 4th year into this grant, and we recruited more than 300 patients. So this has been the consortium has been very successful. Half of our patients have PMM2 CDG because PMM2 CDG is the most frequent CDG, has prevalence of 1 in 20,000, and the rest of the patients have a very long list of different subtypes. So the consortium has 3 major cores. One is biomarker. So we are validating and discovering quantitative biomarker in order to get clinical trial readiness. Another is a natural history core. So these 2 core we started first. So then we have another call for clinical trial. So once we have a very good biomarkers, we also have patients recruited in our consortium, then we can start clinical trial. So we started our first clinical trial in the 2nd year, end of the 2nd year of our consortium. And now in the 4th year, we have more than 6 clinical trials ongoing. We have 3 clinical trials for PMM2 CDG, and then also ongoing clinical trials for PGM1, SLC35C1, and NGLY1 CDG. So I know that every family group are interested in clinical trial, and ultimate goal of all our studies is find the therapy, find the treatment for our patients. So I'm happy to share our experience with you. So this is slides, actually it's old slides that tell you about distribution of all the common CDGs. As I mentioned, that PMM2 CDG is the most common type 1 CDG. So in my career, I spend a lot of time to educate people about PMM2 CDG, educate people about how to pick up, how to recognize PMM2 CDG. And because one of the early clinical signs is failure to thrive. So those patients usually having trouble to gain weight. They are very small babies. So everybody remember that very, very nicely, and they end up only looking for CDG patient with a small baby, with small size, small head size, and without recognizing that in type 2 CDG, the most common type 2 CDG is MAN1B1. Those baby is the opposite of PMM2. So instead of they have small size, they have large size. They often present with microsomia. So you look at overweight baby. One of the typical symptom of MAN1B1 CDG is truncal obesity. So recent years, I have been struggled to convey this message to all the clinicians, fellows, that not only you need to look for CDG in patient that has failure to thrive, you should also looking for CDGs in patient that has a truncal obesity and developmental delay. So that's one of the reasons when I recognize that the Cohen syndrome actually has pretty high frequency in Pennsylvania, then I get involved and try to become one of the voice to advocating to screen for Cohen syndrome, because I hope that the Cohen syndrome can be representative, another representative for CDG in the type 2 CDG, so help people to recognize how to screen for glycosylation disorders in kids that has overweight. So these are some clinical presentations in PMM2 CDG, and basically is clinically they are highly variable. So there are different forms. The most severe one is the early infancy type, and they can present. The first sign usually is always failure to thrive, and they have very obvious feeding problems. They can present with ascites. They can present with overwhelming pericardial effusion. So this is a X-ray of PMM2 CDG baby. That is, unfortunately, he was born at the heat of the pandemics. So for 6 months that he hasn't show up at hospital. The first time he show up at a hospital, this is what his heart looked like. So there's a dramatic, overwhelming pericardial effusion that is so severe. The baby passed away shortly after the diagnosis. So this early infantile PMM2 still has very high mortality. Then another form is milder, that is later infancy. Those patients can present with microcephaly, developmental delay, intellectual disability, seizures. One of the features that is progressive in all PMM2 CDG patients are the cerebellar atrophy. And they usually born with, they can born with normal cerebellum. And with time, those cerebellum volumes start to shrink and they develop ataxia. They can also present with stroke-like episodes, hypertonia, coagulopathy, microcytic anemia are all features for PMM2. Then there's also adult PMM2. So once physicians are good at pick up pediatric PMM2 patient, then it becomes very difficult for them to recognize adult because their clinical presentation are drastically different. So adult PMM2 patient often present with retinitis pigmentosa, ataxia, and peripheral neuropathy. So because clinically CDG patients are very, very difficult to recognize, they are highly diverse. Even the best geneticist can miss them. So laboratory diagnosis become very important. So this is the mass spec machine that we used in my lab to diagnose glycosylation abnormalities in plasma. So this is a machine we call accurate mass and high resolution mass spec. It's a very advanced mass spec. The reason for that is the classic clinical test that is used to pick up CDG is called transferrin test. And the transferrin is a very large protein. So it's 80 kilodalton protein. So in order to do intact protein at very high resolution, we need a mass spec that is very advanced. So this mass spec has a resolution of 1 in 80,000. So that means that when we do the intact protein, we can accurate our mass to 1 dalton. And also this is mass spec can be used for omics application. That means that we will detect everything that we think we know. We will also detect everything we do not know. That means if we discover some new biomarkers, we can look at our large data set retrospectively and find those new markers. Another great capacity for this type of mass spec is they have very broad dynamic range for quantification. So how we do the transferrin test? So if you imagine transferrin is a monomer, and each monomer has 2 glycan on it. And each glycan has 2 antennas. So I often ask our fellow to imagine a glycan is like a bunny. The 2 ears of the glycan is like the bunny's ear. So each bunny has 2 ears. So how we do the transferrin, and if you imagine transferrin is like a car, then each car has 2 bunnies, so 4 ears for each car. And what does my spec do? Actually, it's very simple. We just weigh them. We weigh them all together. And we know each bunny weighs about 2 kilodalton, and the car itself weighs 75 kilodalton. So when we look at a patient sample, if we see a mass of 79 kilodalton, then we know we look at 1 car with 2 bunny, that is normal. If we look at 77 kilodalton, then we know 1 of the bunny is gone. Something is not right. If we look at 75 kilodalton, that means both bunny are gone. That means the glycosylation is completely deficient. So that is how we do the transferrin test. If we see a pattern like this, we give a diagnosis of type 1 CDG. And because our machine has resolution of 1 in 80,000, so we can very accurately measure the transferrin this way. So this is important for CDG because this is a classic test, and almost every CDG is relying on the transferrin test. Of course, there is a big problem with that because transferrin is very much only produced by liver. So if you have a glycosylation disorder, don't have a liver phenotype, such as Cohen syndrome, then the transferrin will not see it. So how we solve this problem? So we basically developed a new test, which is called the plasma N-glycan test. So with this test, instead of just take transferrin from the bloodstream, we take all the glycoprotein from the bloodstream. So if you imagine that transferrin is 1 of the car on the highway, and the bloodstream is like a highway. Instead of taking 1 car, we basically take all the cars from the highway, or you break them apart and release the bunny from the car. So that step, the key for that step is we have to capture the bunny that has steering wheel still on it. Otherwise, it's a free running bunny that has nothing to do with what we want to detect. So if we do this, then put a tag on it, lock the bunny there, and then this compound can light up nicely in the mass spec, allow us to see the whole spectrum of the glycosylation from all the glycoprotein in the plasma. So this is our specialty test. It's actually a very fast test, and we can do 96 samples at the same time. So the reason that we designed it this way is because in the future, we can transform this test to newborn screening. That means we can screen for every newborns for glycosylation disorder and achieve early diagnosis. So another function of our machine is they can also sequence the glycan. So because glycan is highly diverse, and if we find any glycans that has abnormal structures, we can sequence them by our technology and understand the precise components and the structure of the glycan. Now, so this is showing you the linearity. Basically, is showing you the ability to quantify these N-glycans. So once we have this capacity, then we can collect the normal range versus the disease range. So when we say in this particular patient, these glycans increased, we have a very high confidence to say that because this level does not show up in normal patients. So once we have this advanced technology and we look at the transferrin again, and we notice that in addition to the glycan that we all know about, like that bunny that we talked about, we also found many other glycans. They are a lot smaller than the glycan that we know on each normal transferrin. So why we found all those smaller glycans? Because these other glycans, we call it intermediates, because they are partially done. So they basically are made halfway, and they leak out of the biosynthetic pathway just naturally, because the process of making a glycan, not just by one step, but step-by-step process. So each product that made in the middle process, there's a very small portion will leak out that if our machine is sensitive enough, then we can detect them. So the advantage of being able to detect those intermediates is then we can do the reverse engineering and figure out how the glycan is made. Right? This is basically like how the sausage is made in the kitchen. Now we know how the glycan is made. So once we figure this out, then we can identify a very specific steps that is defective in the biosynthesis pathway by looking at those intermediates. Seeing if the MAN2 is increased, then we know the step must be, something must be wrong at this step. Because if this one is slower, this step is slower than the rest of the step, then these intermediates will be accumulating. So this is the trick that we use to identify exactly the glycosylation defect in the patients. So at the CHOP, we routinely monitoring 55 glycans in the plasma. They are picked up because they represent different biosynthetic pathway. So we use these to identify a very specific glycosylation defect. So this you're not meant to see of the glycans, but you can see the color code. So these are basically different CDGs. And the color code of red means it's increased, green means decreased. So you can see in the patient, you will see increase of all the small glycans, and you see a decrease of big glycans, because big glycans is the mature glycan that is the final product in those patients. We often see a decrease because they can't complete the job. And then you see those intermediate, halfway made, partially made glycan increase in those patients. So that's how we make diagnosis for glycosylation defect. So once we have these glycans as diagnostic marker, then we can use them to monitor the therapy. So one example is this is galactose therapy in patients with SLC35A2. So those patients has a very simple defect. They have a defect in transporter for UDP galactose. So one simple solution is give them galactose because they still have some residual transport activity. So by using our biomarker, we can see in this patient, after we giving them galactose, this truncated glycan start to reduce, while this normal glycan start to increase. Then we can calculate the p-value and make a strong case that this therapy is working, at least biochemically. This is called, we also call this as a surrogate biomarkers. So nowadays, FDA often, they used to accept surrogate biomarker really well. But as we do more and more clinical trials and they start to raise the bar, and they really sometimes demand clinical biomarkers. So that just means that, yeah, you see the biochemical improvement, you see, according to the disease mechanism, you see improvement. Does that really improve the quality of life in a patient? So in order to quantify that, what you need is a disease rating scale. So basically, it's quantitatively express the severity of the disease. So you have to establish the rating scale in the natural history and at your clinic. So for CDG, we have a CDG clinic. This is Dr. Andy at Madison. He is in charge of the CDG clinic at CHOP, and he's the person that do the CDG severity score for me. And in order to do this severity score, and we use a scaling system called Nijmegen Pediatric CDG Rating Scale that was developed by Dr. Eva Marova when she was with Nijmegen group. So in this particular rating scale, we separate the rating into 3 different sections. So one is a section that evaluates the functional skill. So basically is a life skill in the patients. And the section 2 is mostly focused on the labs, and that's called system-specific assessment. So for CDG patient, this section 2 is heavily on liver disease because CDG patient has liver disease. And the section 3 is a clinical assessment for growth, development, visual, myopathy, ataxia, and it's heavily scored for neurological abnormalities. And this is what we used for pediatric CDG. And once we had a consortium, we have our own natural history study. We quickly figured out this is inadequate for adult PMM2 patients. So we're developing different scaling system for adult. And for Cohen syndrome, and as we work with Dr. Huang, we also recognize if we want to do a severity score for Cohen syndrome, we really need Dr. Huang to develop a different rating scale. So the severity score will be more specific for Cohen syndrome because that's very different from other CDG patients. So this is showing you how we can correlate with glycosylation changes with the severity score. So these are the 10 different glycans that is abnormal in PMM2 patients. So when we evaluate these biomarkers one by one, we find MAN8, which is a glycan here, not necessarily the best diagnostic marker, but it is a very good prognostic marker because it correlates very well with total severity score. So from this data, and we can predict that when we diagnosed PMM2 in a baby, if the baby has a very low MAN5, then we can predict that very low MAN5 is here, then we can predict the baby will have very severe clinical course. If the MAN5 level is normal, very healthy, then we can predict that the baby will have a much milder clinical course. So clinically, even without therapy, these are very important prognostic markers. So in order to be ready for clinical trial, we start to develop this fractionated N glycan. Basically, we separate glycoprotein from the plasma to IgG fraction, transferrin fraction, and the remaining protein fraction. Because the glycosylation on IgG versus on transferrin are very, very different. The glycosylation in IgG occurred in B cell, versus the glycosylation on transferrin occurred in hepatocytes in liver. So they are drastically different. and hopefully they represent the major glycosylation pathways in body. And the remaining glycoprotein, the plasma, majority of them actually produced from liver as well. So as we do fractionated N-glycan, we start to discover even more markers from each glycoprotein. So we do them semi-quantitatively. Now we found these 6 addition markers from transferrin. You can see these are different. These are different glycans. As we correlate those glycan changes to different sections of severity score, and we found these small high mannose changes actually correlates very well with section 1 score. So that is a little surprise to us because this is transferrin and made in hepatocytes. We thought we'll correlate with section 2, but actually it correlates with the functional assessment. And we also look at N-glycan changes in IgG, and immune deficiency is common in PMM2 CDG patient. They also have frequent infection, but probably not as common as in Cohen syndrome patient, because not every PMM2 patient has immune deficiency. About 60% to 70% of the patients has immune deficiency, and that is consistent with what we see in IgG. So in these patients, we found about 70 to about 60% of these patients has consistent glycosylation changes on IgG. As we correlate with the clinical severity, we found that, again, it actually correlates very well with functional severity, so section 1 score, which is good news because that's often what FDA want to look for, is improvement of quality of life. And it also correlates very well to the severity score. So IgG glycosylation, that is tell us IgG glycosylation is important for the disease. So for the remaining fraction, and we also discovered many glycosylation changes. They all have a very high sensitivity among the patients, like this MAN3 and 4 ratio has the best diagnostic level because every patient has increased 3 and 4 ratio. So far we've tested like more than 70 PMM2 patients, and all of them, 100% has increased 3 and 4 ratio. So that's a very sensitive diagnostic marker for CDG. And in this category, we actually found MAN0 correlates well with the section 2. So this turned out to be a glycan that probably correlate best with liver disease in PMM2 patients. So these are the biomarker studies that we did with PMM2 CDG patients. And these biomarkers actually are essential for this clinical trial, ongoing clinical trial. And because once you start the clinical trial, it's a very long and a complicated process. And at every step, you have to convince investors to invest more money to expand the trial and to increase the dose. And all of these, you have to show strong evidence. Sometimes because the limitation of the period of the time that you have, you may not immediately see improvement of life quality of life. Then you need all those biomarkers to provide evidence and keep the clinical trial going. So for Cohen syndrome, now I move on to Cohen syndrome. Dr. Huang already touched on what is Cohen syndrome. So Cohen syndrome is caused by autosomal recessive mutations in VPS 13B. That's a gene encodes subunit for VPS13 complex. This complex is very important for human because there are 4 different complex. Mutations in each complex cause disease. It is a mandatory membrane protein for Golgi. This protein is very big. That also means that you're going to find a lot of VOUS in this protein. So it's not rare for me to receive samples from patients that found VOUS in VPS13B and ask me to look at clinical evidence to rule. A lot of time is rule out Cohen syndrome because the frequency for VOUS is actually pretty high. In the literature, recently, and a group in Europe found that there are tissue-specific glycosylation defect in Cohen syndrome. And they find that the glycosylation on transferrin and the alpha antitrypsin, both proteins that are made by liver, are completely normal. So we speculate that these glycosylation abnormalities that detected from Cohen syndrome probably is from IgG. And in the literature, they also mentioned there's also abnormal indolysosome trafficking in Cohen syndrome cells. So these are the published data. So in this published data, they indeed showing this fucosylated A-gal, fucosylated monogal, and maybe also a little bit of fucosylated A-cell glycans are increased in Cohen syndrome. And when I look at this data, of course, that is telling me that something probably is wrong with IgG because those are the glycans pretty exclusively present in IgG. So when I met Dr. Morton last year, we collected some samples from Cohen family. They consented to our study. Then Dr. Wang also sent me some samples from the cohort that he saw at the DDC clinic. So these are the 10 patients that we have because one of the patients actually is the parent. She has only has some borderline changes, and a couple of days ago that Dr. Wang told me that P8 is not a patient. I was very happy to remove her from this table. So now all the Cohen patients that I tested has a consistent elevation of this particular glycan called fucosylated MEN2. So this is a surprise to me because if I draw my blood, you will find not a trace of fucosylated MEN2. So this is a very unique glycan. Just very unusual to see. I've seen these fucosylated MEN2 increase in very, very sick children with sepsis, with very, very high white cell count. You can sometimes see a little bit of elevation, but never greater than 0.10. So you can see in Cohen patient, every one of them has increased for fucosylated MEN2. So that was the first glycan that caught my eyes. That's important for one good reason is although this glycan does not exist in the plasma, but it's actually a very specific glycan for neutrophils. And inside the neutrophil, there are a lot of fucosylated MEN2. And it is important glycan for neutrophil maturation. So that basically seeing the development of neutrophil, and also an important glycan for the function of neutrophil. So another glycan we found it is consistently elevated is this fucosylated A-gal. So this is a glycan also reported by other groups. And the difference is other groups is reported it qualitatively. And we basically collected the ranges for normal population and then look at a Cohen syndrome patient. And I found indeed it is increased in majority of the Cohen syndrome patient. The major difference is when I met these 5 children at Dr. Holmes Martin's clinic, they are not sick. They are basically normal kids that play in the conference room. But in the normal population, we only see these increased when a patient is sick. So because of that, it's also very unusual for this to increase in Cohen syndrome. Another thing we noticed that the P5 is the youngest kid. So we noticed that these intend to increase with age. And we also noticed that from the cohort from Dr. Huang, they are in general older than the kids that I met at Dr. Martin's clinic. So that could be another reason that some of Dr. Huang's patient has very high level of this particular glycan. So these glycans actually are very important glycan on IgG, and it determines the function of IgG, determine the toxicity of IgG. So that's potentially could be a very important disease markers for Cohen syndrome. So this is another glycan. This glycan is intermediate glycan that actually is made at cis part of the Golgi. It is one of the rate limiting glycan at a very early step of Golgi-associated glycosylation process. And it is surprising that a majority of these patients has reduced level of this particular glycan. Another thing that really impressed me is from the patient from Dr. Wang's clinic, they actually show the reduction of normal glycan. So that is impressive. That is when I say this is CDG, because in the plasma, this normal glycan is mostly contributed by transferrin, which is produced in the liver. And we all know that liver is not affected in Cohen syndrome. So for this to be reduced in Cohen syndrome, that is unusual. Really convinced me that there is a deficiency in making the normal final product in Cohen syndrome. So another marker that I use frequently for PMM2 patient are the MEN3 and 4 ratio. And it also surprised to me that one of the patients from Dr. Huang's clinic has increased 3 and 4 ratio. That is very unusual because we screen thousands, tens of thousands patients each year. And every time I see increase in a 3 and 4 ratio, almost certain the patient is affected. So this actually reminded me of one of the type 2 CDG we published called ARCN1. That's an autosomal dominant condition, means that those patients only need one mutation to become diseased. And those patients can have intermittent profound glycosylation changes. That means that they don't always have very severe changes, but they only show glycosylation abnormalities when they are sick. So that's also a possibility for Cohen syndrome, and why we see these different severity in biomarkers in Cohen syndrome. So this is slides and help me to explain to you why these glycans, how these glycans can guide us to understand the physiology in neutrophil. So this glycosylation process is maturing as the neutrophil mature. So at a PM status, a neutrophil mostly produce fucosylated MEN2 and fucosylated MEN3. As the neutrophil mature into MC status, these small glycan grow into sialylated glycan. That is the reason that this glycan has to form is because with silation, this neutrophil will obtain the ability to penetrate into the tissue. So one of the function for neutrophil is enter from blood, enter the tissue from the bloodstream. So they are able to fight infection inside the tissue. So if the neutrophil failed to form the mature glycan, they're probably unable to progress from PM status to MC status. So the consequence of that could be the neutropenia that we observed in Cohen syndrome patient. So another important role of this glycan, particularly this fucosylated MEN2, is they are highly enriched in the granules that excreted from neutrophils that stay at a PM stage. That's called azulophilic granule. So those granules are the neutrophils that spit out in the bloodstream that help to fight the infections and trigger the immune response. So that is illustrated here. So if this part of the glycosylation is abnormal, then neutrophil won't be able to fight the infection effectively. So because of that, we also look at all the research glycans. So as I shared with you, we have 55 N-glycan at our clinical panel. We also have more than 180 glycans in the research panel. So we analyzed those glycans in the research panel, and we found that not only the fucosylated MEN2, also the fucosylated MEN3 increased in Cohen syndrome patients. And also those under-glycosylated glycan that is important for immune function also increased. So not only the fucosylated AGL, but also other glycans share the same feature, also increased. So interestingly, I found this bisected biotinary glycan actually reduced in Cohen syndrome patients. So that is new because that's not reported before. Bisected biotinary glycans has very important pro-inflammatory function. So that means that if this is come from IgG, then that means the IgG actually has reduced capability to fight the infection. So all of those important biomarkers potentially can be associated with disease. Another thing to mention is this particular increase of underglycosylation is also observed in another disease called GSD1B. So that's a condition that also leads to glycosylation abnormality and neutropenia. Mouse model for GSD1B is actually showing they respond to mannose supplement. And to our surprise, that those mouse actually their glycosylation can significantly improve, and their ability to fight infection significantly improved when they are on mannose supplement. So glycosylation, basically, I think the message is it always surprises us how the glycosylation can respond to therapy, and how the therapy that improves glycosylation can improve the immunity in disease model. So in summary, I hope that I share our experience with you that it is important to establish the clinical trial readiness. Almost every clinical trial will ask whether you have a natural history study. At CHOP, we're often approached by numerous companies and asking for a clinical trial. The first question is always, do you have a natural history? If you don't have a natural history, then physicians has no way to conduct a trial because we don't have a baseline to compare to. And a disease biomarker that developed a severity score that developed from natural history is essential because that's something that FDA always asks. Sometimes clinical trials are extremely expensive. If you're not ready and you do the clinical trial and you can fail the trial, once it's failed, then it's very, very difficult for anyone to pick up this project again. So it's very important that if you want to develop a clinical trial, you should get a clinical trial readiness to established. And in addition to quantitative disease biomarkers, and it's also important to have biochemical surrogate biomarkers. And for Cohen syndrome, the IgG and glycan or leukocyte, neutrophil and glycans can be great candidates. And also the leukocyte functional study by measure the neutrophil oxidative burst, look at NADPH oxidase complex, because this is a complex that is essential to neutrophil function. And those complexes are made by glycoprotein. Therefore, they are also a very good candidate for further research. And once you established quantitative biomarker and you have natural history, then you can do the disease correlation studies that will help you discover therapeutic biomarkers, because prognostic biomarkers often different from prognosis biomarker. And all those biomarkers are often different from therapeutic biomarker, because therapeutic biomarker has to correlate with disease. And with these studies, you can also uncover new disease mechanism and help you to devise therapeutic strategies that is specific for your disease. And finally is one of the most successful thing that we do in genetics field is newborn screening. And if we can screen for Cohen syndrome at newborn, that will give us a window of opportunity to develop therapies for this condition. So thank you for your attention. This is my acknowledgement. I thank all my lab members, thank my collaborators, Dr. Huang from DDC Clinic, and also Dr. Taosen Huang from University of Buffalo, and Dr. Holmes Martin from the Central Pennsylvania Clinic. When Dr. Huang saying that we established Cohen syndrome research consortium, and he's referring to 4 of us. So I also thank all the family group from the CDG community, and thank the grant funding. Thank you for your attention.
Oh, thank you so much. That